sometimes you have a really stubborn shoulder that doesn't want to get better. So one of the things that happens sometimes is the scapula will actually slip over on the back of the shoulder. It'll actually slip out of place, so it's kind of flipping up like a winged scapula, and it'll stymie all your efforts to correct everything. You can get everything all well corrected, and it still bothers the person because it's still not aligned correctly. So I have a little drop technique that I use to drop that scapula down, and it helps set the scapula, which is like the base of the shoulder, into place, and that's where the humerus socket is. So it will actually help you to correct the shoulder problem. So the way I do this is I have the drop like this, and you can actually do this by just stretching the patient. If you want to sit them up and just stretch that, sometimes that's what I have to resort to, is just stretching everything back down into place. But what I do is I just kind of catch the scapula like that and drop it down like this to set it back into place where it's supposed to be. And it'll help that scapula that has slipped off just a little bit to get back in the right place, putting the socket for the shoulder in the correct place so that everything else you do works. Usually when that happens, there's usually some kind of a rib involvement too, so the ribs will actually, you can actually feel the ribs will be popped up out of place too. So you can tuck the ribs in down here like I showed you before, like this. You want to tuck those ribs as you go. You'll usually feel one or two of them that are really lateral. You'll feel a little bump over where it shouldn't be, and that's usually the worst part of the rib subluxation, so that's the one you want to concentrate on, and you want to tuck them in and drop as you tuck. Then you can go up here or under the arm, and you let their arm up over like this, and sometimes these upper ribs are right under the armpit here. You can feel where they're sticking out. Sorry, am I tickling you? So you want to actually set those ribs down in where they're supposed to be. Again, being very careful to stay off of the angle of the rib because you don't want to have any ribs crack on you. So this is where they seem to be very vulnerable in here, so be very careful when you're in there. Use your pad, use the flat of your hand, never do knife edge contacts on that. So use the flat of your hand, and you always want to drop ribs down. You don't want to flip them back up. That's what they want to do, but you want to drop them down. Like this. You want to go superior to inferior with them. Okay. Okay. Good. Turn on your back. So now with the ribs also, sometimes they'll get tweaked forward on one side or the other. So you can do a little this tucking with the flat of your hand on the side too, like tuck them around. You need to kind of keep moving them back where they're supposed to be. So we'll be tucking them here. And again, be careful, especially when you're working on your women patients. Just stay off the breast tissue if you can. I like these little pads for this. This is really good for a male doctor, especially because it kind of gives you a little something between your hand and the patient's chest area. I usually try to stay right down the center here of the sternum area when I'm adjusting the ribs. But occasionally, if you have a heartburn problem or something like that, you may have to actually work with the individual ribs, because sometimes those ribs will actually kind of twist and turn on their own in there. So you have to kind of directly work on that. And I'll talk to you a little bit more about that in a minute. But I usually try to stay down the center line, on the sides, on the back. I try not to actually do too much contact right on the breast area, because a lot of women are sore there anyway, even if it isn't a modesty issue. But the modesty issue is a big one. If you have a patient that's so sore that they can't even hardly stand you to touch it, which I have had, I had one lady that face planted herself when she was stealing bases in a softball game, and she ended up throwing all her ribs out because she had her arms up like that. And she couldn't even stand me to touch her ribs. They were so painful. So what I do in those cases is I have the patient put their own hand over the rib like that, and I adjust right through their hand. I just right over their hand. That way it gives them a little more confidence, and it makes them feel a little bit more secure that it's not going to hurt. So what I do with this case is I'll just take her hand and I'll use her hand to adjust the rib. So that really helps take some of the fear out of it. If they're really in pain or if they're really nervous about it, it's a good way to do that and still get an effective adjustment. You can also just put the pad over and use the pad for your contact to actually work on the ribs. Now, if you have one of those ribs that's kind of twisted in there, it usually hurts. It feels like a side ache. It'll feel like you're getting one of those side ache pains, like a little sharp stabby pain. Ribs are really big for sharp stabbing pains. That's one of their favorite ways to talk to you, is they'll give you a really nice sharp knife in the back, kind of stabby pain. So, but if they twist around, it'll be kind of subtle. It'll be certain positions or certain ways they're breathing, and they'll feel that little, like a side ache feeling. So when they twist around in there, the way to correct them is you want to push up on the rib and find out exactly which rib is involved. And then usually when I'm testing ribs, I'm going to do it with 1 or 2 fingers and push them up this way. This is how I test, like that. She's got a little bit of anteriority on the side, so she's testing weak. But if you have one in question, such as the heartburn rib, which is about rib 4 and 5, that's a really common one. When somebody has heartburn, they're usually getting twisted up in there. And that's the one that goes to the esophageal sphincter and can give you the acid reflux problem. So when I have a twisted rib, I'm going to show you first with my thumbs. I would catch it and flip it down. Usually it twists up. It can twist down, so be sure you test. Usually it doesn't, though. Usually it flips up. So you just take that and you flip it down like this. You want both of those drops working the lightest possible tension. So you just flip them down all the way around. You want to go along this whole angle of the rib here, all the way around, flipping them down. And I like the double drop on ribs again. I use double drop on almost everything. I set both drops to go at the same tension. So just stay on the sternum area, because usually you can feel them the best there when they're popping out of place. You can feel the ribs sticking up the most. And sometimes, be careful, but this is usually a pretty strong place because the cartilage is all through here, all the way down out to here is pretty much cartilage. So you're not going to take so much of a risk of cracking anything. So be really careful when you're doing these ribs, and especially along the angle right over here. When you're working on the ribs, one of the things I like to do when I'm looking for a rib vertebrae complex that's not in alignment is I like to feel right down along the edge of the spinuses on the side. You can usually feel them, and your patient will usually confirm that's sore when I touch the ones that are out. They usually feel like they're twisted over. You can feel them bumping up on the side where you shouldn't. You should feel like a nice little straight, like a little string of pearls. But if you have some vertebrae rib complex that's misaligned, it'll flip up and you'll feel this kind of a bump on the side that it shouldn't be there. So that's how I feel them. There's one right here on her. That is one. You can tell, huh? Your patient will tell you that's out. And this is one too. So she's got a couple of those little guys. So what I'm going to do is catch that, and we're going to tuck that down in like that rib vertebrae. And I'm using I usually come from this side, but I'm trying to stay out of the way so I can show you. But I use the rib to drive the vertebrae into place. So I catch the rib with the flat of my hand. Again, I'm not using any kind of pinpoint or knife point contact. And drop it down and tuck it in. We're going to tuck it in like this. And sometimes they'll get jammed up really hard superior, and so you can just kind of tuck them down like this. This isn't dropping correctly. Okay, that's better. See, the double drop just makes a huge difference. One drop doesn't quite do it. And now that feels a little better. Okay, we're going to tuck that back in. Probably did that yesterday, huh? Okay. And I just kind of go back and feel it. I do a couple of drops and I go back and feel it. Now sometimes they're very stubborn, and in this case you want to get out your gun here and go right on that vertebrae that's sticking out. Is that right now? I got it in pretty good, but like that, and just give it a little extra push. And that actually should correct it. So once you correct it, you should be able to run your finger over it, and it doesn't feel that bad anymore. It doesn't really hurt so much anymore. Okay. And she had another little one up here, so she's got one here at T2. Now, T2 will cause breathing problems, as we discussed earlier. Sometimes if you have asthma or something, T2 will be quite instigator for having an asthma attack. Okay. And if you have one of these up at T2, remember again, you want to bring that arm up over your head, get the arm out of the way, and so you can get to these ribs in here, these upper ribs. And it may be just a little ticklish, but if you use your pad, if somebody's ticklish, you can always use your pad. But I find that you can actually feel the ones that are not in alignment by just running your hand over that. Okay. You're going to kind of find a theme to the way I treat these problems, and you're going to see that I treat them usually from the front, from the side, and from the back. I treat things from each position. So same thing with an SI problem. I usually treat the sacrum from the back, treat the ilium from the side, turn them over and treat the anteriority from the front. And same thing with ribs. You need to treat this first along here. You want to get these little twisted rib vertebrae out of place, because if you don't correct that and you just go ahead and correct the rib from each direction, that's going to drive that rib right back out. So as soon as the person starts getting up and moving around, they're going to find that rib's popping out again, and all the symptoms come back. So the first thing to do is to set the spine into place. You want to set the spine into place, and then you want to set the rib into place. So once I get the spine set in with these little twisted vertebrae here, then the rib will stay a lot better. So again, you use the rib to drive, use the flat hand contact, touch it, catch it, and kind of tuck it in as you go up and down the spine. Then you want to turn the person flat on their back. And you're not going to correct the pain in the rib unless you do all these sides. Unless you take all of these steps, you're still going to have the person having problems. So when I work on these, I always turn them back on their back, and I do the front, the anteriority, I take it out last, because by then you've freed up all the complexes that were pushing that rib and vertebrae anterior, and you can actually fix that. Sometimes they need a regular anterior adjustment with this, so it's kind of a judgment call. It depends on whether you think they need it or not. Sometimes I do posteriors on them, sometimes I do anteriors, depending on what I feel like their ribs are doing. But usually when I do anteriors, I use this little device here called a cookie. And I think the company that originally made these has gone out of business, but it has like 2 broom handles in here. So it's just the same thing as if I had my hand under there. I found that I got a lot of hand problems and wrist and rib problems from doing the regular anterior adjustment, where you put your arm around them and use your hand, and then you're actually leaping on your own hand underneath the patient's body with all your force. So you're smashing your hand. Depending on how many times you do that a day, you're going to get wrist problems, you're going to get hand problems, you're going to get rib problems from that. So I find that this works better. There is another way you can do anteriors that's really helpful. You can take a washcloth or a towel or one of these pads and roll it up real tight and hold it in your hand, and that actually supports your hand when you're doing the anterior, and it'll actually help keep from crushing your hand so much and giving your hand so many hand problems. So that's one of the things I like to do. Sometimes I'll do an anterior on them. Sometimes if it feels like they've got a lot of convexity in their rib cage, I'll do posteriors on them. But always be careful that you don't push that anterior rib more anterior.